All right, we're going to get started. Hi, everyone. Thank you for coming tonight. If this is your first WCVIS Chicago event, thank you for coming. Today, we're going to be having a panel. It's a day in the life of a VIR resident. My name is Nick Pruce. I'll be the host and moderator, and I'm currently a first year at UIC. So I want to give a brief intro on WCVIS Chicago. So the Chicago chapter of WCVIS is a student-run organization with a mission to foster early education and exposure to the field of endovascular and interventional surgery. Our aim is to connect surgically minded trainees in Chicago with a deep interest in minimally invasive approaches to patient care. We seek to clarify that this field is intended for trainees interested solely in surgery and hands-on patient care rather than for those interested in image interpretation. If you've not connected with us yet, we have two QR codes on the screen. The left is a membership form. You can fill it out quickly, and we send out emails on a regular basis about new events and just other stuff that's going on in the field. And then the QR code to the right takes you to our GroupMe. And I know not all members are in the GroupMe, so if you're here today and you're not in it, I think it's a great place to join. This is an event I want to quickly promote. So the main WCVIS organization, they have a yearly symposium. And in February, they have one that's happening on a Saturday and Sunday. It's on the 7th and 8th. There's a QR code on the right-hand side of the screen where you can register. There's going to be a lot of big names that are attending and are speaking. The sessions are on basically everything VAR. So you have oncology, MSK, everything that you can think of. There's a PD panel also. So if you're really interested in VAR, I think this is a great thing to attend. All right, since we have two residents joining us today, I think it's important to talk about the three training pathways to go into IR. This is a graphic that I got from the Society of Interventional Radiology. The most well-known pathway is the integrated. It's also the newest, I believe, just started in 2017. All three pathways all have an intern year. A lot of residents choose between like internal medicine or general surgery, but there's definitely a growing preference towards general surgery. And I think that's going to be touched on in this meeting. An integrated first 3 years are mainly DR focused, but there's also three IR rotations. And then the last two are focused on IR, and it's a total of 6 years. Then you have the independent pathway. So here you match into a DR program, and then you have 4 years in that, and then you would have to apply for an IR fellowship. And this is the longest pathway of 7 years. And then you have ESIR, and this is kind of like a blend between the integrated and independent. You would be matching into a DR program, but you'd make a preference towards a an IR training. So your first 4 years are like a blend between DR, IR, and then your last year is only focused on IR. And now I'll introduce our awesome presenters. I'll first let Mary Louise introduce herself.
Hi everyone, my name is Marie Louise. I'm a PGY4, so R3 radiology resident over at UIC. Um, I grew up outside of Chicago, went to undergrad in Cleveland at Case Western, went to med school actually at UIC, did my intern year in internal medicine at the Medical College of Wisconsin up in Milwaukee, and then came back down here and I'm happy to be sticking around in Chicago for my residency. So currently, like on that training path, I'm in my last year of diagnostic radiology. Going to be taking the core exam over the summer, and then be starting on like my dedicated IR years coming up in July. So happy to be here chatting with you all.
Awesome. Thank you for joining us. And then I'll let Subash introduce himself.
Yeah, thanks for the intro, Nick. Good evening, guys, and great job for organizing everything. And thanks to our audience members for coming out. My name is Subash. I'm a Rush resident, PGY3. I did undergrad at Vanderbilt, med school at George Washington in DC, and now I'm here at Rush in Chicago. Um, and kind of in figuring out what to do for this presentation, I'm more of a visual learner. I wanted to keep things kind of fun and engaging, so I prepped a few slides. But before we get into my personal journey, I just want to offer my thoughts on what I think about VIR as a field and what makes it unique. So let's go to the next slide, Nick. So some of you guys have probably seen this meme already on Med Twitter or Instagram or whatnot. And it's funny, but it's also just like so accurate. What's cool about VIR is that you get all these very different roles. You wear these very different hats. Plumber, surgeon, radiologist, MacGyver. You're put in situations where you're solving problems for the first time using the tools in your toolkit. And really, there's no other field where you're doing like where you're combining all these different skill sets. And I think that's one of the things that makes us so well equipped and so powerful as a specialty. But in order to kind of wear all these different hats, can we go to the next slide, Nick? You have to pick up all these different attributes. You have to refine all these different skills over the course of your training and beyond. So, jokingly, I refer to them as like the infinity stones of VIR. And I'm just in my head, I'm imagining Thanos with his gauntlet and kind of attaching all these different stones as he goes through his training. And I have to give credit where it's due. Dr. Vatican Cherry actually came up with all these different five concepts, and he called them the pillars of VIR. And he taught us when we were on our sub-I with him a few years ago. But the concepts are the same: clinical, imaging, procedural. We get all those things during our training. If you want to go to the next slide, Nick. Um, but practice building and the politics of healthcare, that's not like a formal part of our training usually, but some might say they're equally important or maybe even the most important parts of being a good VIR, because if you can't do those two things, you may never get the patient into your door and on your procedure table, and you may never get to put those skills to good use. But as you can see here, we have just such a disjointed training pathway. From year to year, we're doing such different things. But we pick up all these different skills along the way. So we can go to the next slide. So yeah, I just want to show you guys some pictures. So at Rush, whenever you match at Rush, if you as part of our categorical program, they automatically place you into a general surgery intern year. So here's just some different parts of my journey. On the left there, that's me and Shiv, my VIR co-resident, on nights together. That second pic there, it's us at our general surgery holiday party. And everybody in the back, those are our general surgery co-residents. And it's so much fun kind of hopping from department to department as you go through training because you just become close friends with so many different tribes of people. And a couple of years in, every time you walk through the hallway, you have like so many different friends all over the place. And it's just socially, it's a lot of fun. And you also learn so much. That fourth pick, uh, putting some betadine on somebody's foot wound, rotating on vascular surgery service and learning wound care, all those skills become important down the road. And then the last pick is me scrubbed into an OR case. This one was a carotid endarterectomy, and there's just blood like all over my face because the surgery attending at one point he just kind of made a hole in the carotid, let go of it, and just pulsatile blood hitting me in the face. But for me, like the surgery year, it wasn't so much about learning how to do open surgery and learning how to operate. It was more so the clinical aspect. And you're all the senior residents and the attendings, they're busy all day operating. They're in the operating room. Nobody's there to help you for the most part. So even as a first year, you become really autonomous, you become comfortable managing lots of different problems. And I'm not sure, Marie Louise, if you did a surgery year, but medicine year, TY years, you learn a lot of these skills as well. And I'm excited to hear your perspective. All right, Nick, we can go to the next slide. So then in the middle of the journey, you go to the diagnostic years, the DR years. So in my program, we do at least 10 out of the 12 months a year on diagnostic from years 2 through 4. And for me in particular, I don't know. I feel like I have a weird relationship with DR because I did not have any interest in it at all when I was going into it. I never did a single DR rotation when I was a medical student, and I always thought like, okay, I want to be like a hardcore clinical surgically minded VIR attending one day. I'm not interested in doing a lot of DR in my future job. But it was such a culture shock switching from fast-paced, adrenaline, extroverted surgery lifestyle to suddenly just the next day going to DR where you're sitting in a dark room, everybody's more introverted, you're sitting at a desk like 12 hours a day, and totally different culture, totally different change of pace. And I didn't love it for a long time. All of my PGY or yeah, all of the R1 year. I didn't have fun. It was like a foreign language to me. And I remember I hopped on a phone call with Dr. Vatican Cherry and I was like, man, I don't know if this is for me. Like, I don't know if I can do this for 3 years. And he said, look, maybe it's not in the cards in your future career, but you still have to learn it to be good at IR. And just like, in medical school, learning the USMLE, step exams and all that, you have to sit down and just learn this stuff. And it becomes a lot more fun once you actually understand what's going on, once you speak the language of diagnostic radiology. So that picture in the middle there, that's one of my call cases overnight when I was alone in the hospital. And this lady comes in, she's a family of hospital staff comes in with abdominal pain. You see this giant AAA, I think it's probably like 10 centimeters, and all this complex fluid around it. That's all blood products. So this is a ruptured AAA. She has about 50-60% chance of dying within a couple hours. But I was like, I saw it. Fortunately, I knew what it was. Instantly, I call everybody, and we were able to save her life. And it was a cool case because you'll see that top left picture. That's all VIR residents. So our first year surgery VIR resident, he sounded off all the alarms in the hospital, got her up to the OR. I read the case as a PGY3, and then our VIR fellow, who's wearing that gray lead, he's the one who did the case. He did an emergent EVAR to save this lady's life. And then that's in the bottom right corner. That's us jumping up and down, just super excited about it. Now we can go to the next slide now. And then at the end of your journey, eventually you go full-time VIR, obviously mastering the procedural part. And I haven't gotten to that part of the journey yet. We just kind of sprinkle in 2 months a year during our junior years. But whenever I'm on VIR, I kind of remember like, oh wow, like thank God I'm gonna eventually be doing this full time. It's so much fun. We work hard. We put a lot of time and effort into this part of the training, but it's super satisfying and just a big dopamine kick every day. Um, so yeah, that's been my journey so far, I guess. Nick, do you want to kind of transition to questions or
Yeah,
where
yeah,
do you
yeah.
want to take it?
Isn't there one last slide?
Oh yeah, yeah, yeah. There is. But yeah, so I don't know. We spend so many hours at work, not only as medical students just studying so hard, but also as residents actually doing the training. And eventually we'll become attendings and also spend a huge chunk of our lives at work. But we're lucky, we're one of the few fields, one of the few professions where we actually like our jobs. And, we get to help a lot of people, we get to have a lot of fun, and, we're compensated nicely. But I just want to show you guys, like, you know, I know you're all grinding. You're all like a lot of these guys have a shelf exam tomorrow and they still wanted to come here. But it's all worth it at the end. When the pressure's off, you match into residency, you can kind of relax. And even on a weekday, on a random night on a weekday or on the weekends, there's so much fun to be had. You meet like so many tribes of people in the hospital and so many great friends and who become family. Um, so I just want to let you guys know there's a light at the end of the tunnel.
Awesome. Thank you very much for both of your introductions. We're going to transition to questions now. I have a list of questions that I'm prepared to ask, but if anyone that's joining us today, if you have a question, feel free to raise your hand. I'll try and spot you out and call on you. If not, you can type your question in the chat. I'm also going to save like around 10 to 15 minutes at the end of our session today So that will also be a good time to ask questions. So I want to first start with just a general overview of your day to day. If you can touch on like what time you get to the hospital, what time you leave, do you have didactics every single day? And then also how long are you in the IR suite for?
For this one, are you looking like specifically for IR day to day, or do you want to know about the DR stuff too?
Yeah, I think hearing about both would be awesome.
Yeah. I'll start. So for DR, easier to explain. It's pretty 8 to 5, unless you're on call or swing shift. At UIC, we have didactics every day over lunch. So we have a noon to 12:45 lecture. Um, Typically a smattering of topics. We typically have attendings who like are in that specific field, given that lecture, and then we have a dedicated half hour for lunch that's protected. The attendings cover the lists and everything. And then we go back to reading. We also get once a week IR lectures on Wednesday morning. There'll be like a dedicated one for just the IR integrated residents from 7 to 8, and then 8 to 9 is an IR lecture that like more pertains to like the whole like DR class as well. So it's nice to, even when you're not in IR, get like a little dose of like, ooh, now I get to think about portal hypertension, or something that I enjoy. Um, as far as IR goes, we typically round at about 7:15. Folks get in around 6:30 in the morning, to be able to run on patients, take a look at the schedule for the day. And then after we round, we're going all day until the work is done. Typically, the last scheduled case is somewhere around like 4:30, scheduled to end before 6. But usually there are like inpatient add-ons, that kind of thing. The call resident's the one who typically stays a little later to do those, but if there's more than one thing to do, we like to stick around and help each other out. So, yeah.
Yeah, on my side, pretty similar structure. So during the DR years, your hours are pretty cush. Like we get in at 7:30, we finish at 4 p.m. And after that, you kind of just have the rest of your day to do whatever you want. So if you're a responsible person, maybe you'll spend some time every day studying a little bit. I haven't been so great at that as, I try to fit in where I can, but as you get further along in the journey, eventually you have to take your core exam. I'm sure, Marie Louise, that's probably coming up for you soon, right? So, but you have so much time during the day during the DR years, and but it's totally the work schedule is totally different if you're on the IR block. So IR block, we have one of the longer days probably amongst programs. Our IR days start at 6 a.m. And then every day when you're on IR, we have a lecture from 7 till 8 a.m. Or most days we do that. And then we have cases that start about 8 a.m. and kind of just go until we feel like we got everything done that needed to get done that day. And that could be really any time. So whenever it's the start of the year and all the fellows are new and people are not super skilled and super efficient yet, it's not uncommon for everybody to stay until like, I don't know, 8, 9 p.m. And then as the year goes on, people get better and better and more efficient, and people can leave anywhere between like 5 or 6 p.m. Maybe one room will stay late, but it's really just a culture of whenever the job gets done.
Awesome. Thank you for both of your answers. Seems like there's a lot of similarities, but there's also some differences in the programs. Subash, you talked about how studying when you get home. Is there anything else that both of you do when you get home? Do you prep for cases the next day? Does your program have certain expectations of you?
I think on a busy schedule like IR, whatever studying you can fit in is good. I do try to look forward because we typically stick in the same like room or couple rooms for the week at a time. So I typically try to look forward at the end of the workday for what I'm having for the next day. So if there is a specific case that I've not been in very much, read up on the anatomy, or specific tools that I don't use as often. But honestly, like especially with inpatient consults that come through, which is kind of like a lot of the afternoon, there's a lot that you kind of need to be able to um, like catch up with or go with the flow, like on your feet throughout the day. We have pretty quick room turnover times. It's about like 30 minutes, a little less, depending. So by the time, you're done, you've sent your patient off, you're consenting the next one, all that, you have a little bit of time to read up on the next thing. So, but once you kind of get into the swing of things, yeah, I think just glancing at your patients ahead of time, but it doesn't take quite as much like long prep work the night before.
Yeah, in my experience, I feel like the vast majority of learning I've done is on the job and not so much like at home studying. But you have to keep in mind, I'm at a point in my journey where I don't have like an impending board exam. I kind of have a little bit more time, just because I'm a year behind Marie Louise. So on the DR side, um, I'm a firm believer that the way that you learn, at least initially, is just flying through a bunch of cases and seeing as many things as you can see and just reading a very high volume. And I remember kind of early on, I used to like try to spend a lot of time on one scan and like try to really pick apart everything, and my brain just wasn't like forming whatever neuronal synapse connections that it needed to do. It wasn't until I started taking call during my second year that I'd be reading like 100 studies a night, and then suddenly everything just started like clicking for me. So on the DR side, you just read so many studies a day, and then you see what you got right, what you got wrong, and then the attending will either tell you directly, or you see what they corrected in your report, and then you go back and fix your mis or like see what you missed, learn from your own mistakes, and then rinse and repeat, rinse and repeat, rinse and repeat. And with time, you just like you get so good at the common things, and maybe some rare things you might miss it, but then eventually you see it, get it wrong, and then the next time you get it right. So that's been my DR journey so far. On the IR side, our days are so long, we work really hard, and there's not a whole lot of time to just like be studying with your head in the books when you're on your IR rotations. But we're fortunate, we have a good number of lectures a week, and honestly, if you go to those consistently, you pay attention, just from that alone, you learn a ton. But I totally agree with what Marie Louise said. Like the majority of my at-home preparation when I'm on IR is simply preparing for the patient I'm going to be working on the next day. I want to know everything about that patient. I want to know what their imaging looks like. I want to make sure this is the right procedure. And the rule of thumb is when you're operating, the more you know about the procedure, the better you know the steps, the more you actually get to do, and the more you get out of it. So my attendings, they're like, all right, do you know exactly how to do this from point A to point Z? If the answer is yes, do it. If you mess up, or if you don't know, or if you're struggling, then you kind of give up the case and the attending jumps in. So it's graduated responsibility.
Awesome. The chat is very, very active. I do want to ask if Taiwo has a question. Sorry for if I mispronounced their name, but I think they have a question.
Oh no, it's fine. Thank you. Hi, good evening, everyone. To the current residents, I just wanted to ask because you kind of already talked about it a little bit, because I wanted to mainly ask how you feel like your individual residency programs support you with studying, because I'm assuming like studying for boards like specifically and also doing calls, like even though the calls help you, it's still tiring, like it's a lot going on at once. So I just wanted to ask, like, what other kind of support are you usually offered, like in any capacity?
Um, Mine are impending in terms of the core, so I guess I'll take this one. Um, the way that it works for us, is we have a few resources. We have Rad Primer, which is like a question bank. Most residency programs use that one. We have a couple other just like more reference resources, like StatDX, which is kind of like an encyclopedia, it gives a good differential, good images, some anatomy resources, and then we also have a, oh my gosh, what's the word? A fund for like whatever like academic things that we want to buy. Nice thing at UIC, kind of part of our union contract, is it's just $3,000 a year that gets put into your paycheck, instead of having to ask for reimbursement. So you can kind of spend that how you see fit. If you get a lot of resources for free, you don't have to like lose that money or try and spend it on something that you won't use. Um, and then once we get to our, PGY4, our 3 year, everyone takes a month off at some point for a conference called AIRP. It's a radiology pathology correlation course. Um, Initially, it used to be like, I think you can still do it in person in DC, but since COVID happened, it's mostly remote. They're pretty good lectures from, some really smart radiology attendings. That's pretty DR focused. But it's just a nice time to, go through kind of all the systems. Also, if it's a more boring lecture, you can sit and do your flashcards or read your other resources. Um, so we do that, and there's, quizzes, that kind of thing, and it's just like a helpful pause in the year. And then we have a pretty free 3 months leading up to the core exam. They put us on very light rotations, and we're not expected to like work a whole lot. Um, it's they make a significant effort for us to not have to be working during that time, so that we can just kind of focus on buckling down and studying. So unfortunately, the core exam is it has some step one vibes in terms of there's a lot of trivia that you need to know just to pass. Some of it you might use, some of it you might not. It's helpful to kind of synthesize stuff. You're like, all right, I know what this looks like. I know what the pathology process is because I've been reading these studies and calling these diagnoses. But it's nice to like make that a little fuller. Yeah, and then in terms of IR board prep. Um, that's a little less of a concern. I think some of the stuff, like once you've gone through, your years of training, you have a little bit of time once you're out into practice before you have to take that exam. We get all of our lectures a couple hours a week on the IR side. And then we just do also like throughout the year, like case conferences where, the attending will pull up an image and you have to stand there and like oral board style. They, we'll walk you through, have you like go start to finish, making the diagnosis, making your recommendations, explaining how you do the procedure, concerns for complications, post-procedure care, that kind of thing.
Thank you so much. That was really helpful.
We have Asher who also has his hand raised. Unless, sorry, Subash, do you wanna take a stab at that question?
No, no, I feel like Marie Louise probably covered it way better than I could. I haven't really needed to access much in terms of support at this part of my journey, but we have pretty much all the same kind of resources that you guys do.
Yeah.
Except you guys
Okay.
get a lot more money in like educational funds, so maybe we have to unionize too. Maybe that's the solution.
It can help with some things for sure.
All right, I'll be in touch.
All right. I'll let Asher ask his question and then we'll start transitioning to the questions in the chat.
Yeah, thanks. Thank you again for both of you guys for the great explanation beforehand. And I just want to ask, because Subhash, I know you touched on it a little bit in the beginning of your presentation where you talked about autonomy. And I was just curious for both of you, how's your autonomy like progressed as you went along? And then just another additional thing, like just curious, when it comes to both your institutions, like what kinds of procedures or imaging do you feel really comfortable at, like in this point in your career, and like where do you feel like you're at, in terms of like autonomy, basically?
Yeah, so are we talking more on the IR side or DR side or
I
both?
mean, both, if that's yeah, you can speak
Yeah,
to both.
sure, sure. So on the DR side, basically your entire first year of DR, you have the training wheels on. So but it makes sense because there's such a big learning curve, and it's kind of like med school where every month you're on a different block and like learning everything all over again. And it's the same thing on DR because you'll go from chest radiology to peds radiology to neuroradiology. So it's a big learning curve month after month after month. So all of R1, none of the reports that you create go out live. They all have to get kind of reviewed by an attending and make sure everything's sounding right before it goes live. Then one day you graduate from R1 and you go to R2, and then bam, you're suddenly like a real DR resident. Everything that you say goes out live into the EMR, and suddenly you start taking call. At my hospital, we do independent call. There's no attending overnight. If it was a true emergency, you needed to call somebody, you could, but that's rarely do we do that, and we're all by ourselves, even super early on. So from your second year of DR, you learn how to become very autonomous and very busy and high acuity and stressful situations. And I'm not gonna lie, it's super scary, it's super stressful when you're first starting out for the first month, but it's like shock to the system, sink or swim. And honestly, I learned so much doing that, and I feel like it was great for my growth. Now, having a month or two under my belt and doing it like on month three, taking call on month three, I feel way more comfortable. Like it's like night and day. So I thought it was like a good part of the journey to go through. On IR, like I said, it's graduated autonomy. I think kind of like the idea is by the time you start fellow years, it's nice if you're comfortable with the bread and butter stuff like lines, ports, drains, biopsies, CT guided procedures, and those kinds of things. But it's not like like I remember when I was in your guys' shoes, I'd be like, oh, but the Sinai resident said he can do a Eufy by PGY4, whereas this guy could, he's still learning how to do a port at PGY4. And I was like trying to draw conclusions from it. But on now that I'm on the other side, my advice to you guys is don't worry too much about what your skill level is until you get to your full-time fellow years, like PGY 5, 6. Because whatever, like, okay, you may get good at some bread and butter procedure, then you leave for a few months and you forget how to do it, and then you come back and you're kind of relearning it. But once you're doing it full time for a couple of months, you're gonna exponentially grow. And like, it doesn't matter if somebody was way better than you a year ago, like everybody will catch up very quickly. And the big learning happens during PGY 5. So like, don't even worry about oh, this guy's lapping me or this guy's passing me up. It's not super important, in my opinion.
I think that was a pretty good, overview, especially I think in the using what procedures for what is the measuring tape for how advanced somebody is in IR. I'd say on the IR side, I think you make a good point about getting comfortable with the bread and butter. I'd say that I can do like venous access ports, independently. Pretty comfortable with most drains unless they're in a wacky spot, and I'm not trying to hit anything important. And then, getting comfortable more so with arterial access, and then ultrasound guided biopsies of larger solid organs. I'd say, yeah, we do a lot of, liver, kidney biopsies. But I think that, yeah, and to your point, I've had senior residents who, their first week, month of IR as, in their dedicated time, they're able to maybe do like an arterial case start to finish because that's where they spent more time as, maybe in the year prior, where others, and they may struggle a little bit more with their, native kidney biopsies where it might be the opposite for somebody else going through. But yeah, and similarly to the way that we do our rotations with IR, it's a little different than Rush. We just do 4 weeks in our R1 year, and then we do 6 and 6 in our 2 year and our 3 year. It's about a year between the first like month rotation and the first 6 week rotation. And so it's very much like a wow, I don't remember how to find my needle, my hands don't work kind of experience, but it comes back more and more quickly. And then it's a little less than 6 months between the second two rotations. So it's a nice way to build some confidence. Our attendings are similar with most of them want to at least watch you do a procedure once, even if you are like, I feel comfortable with the steps. But then once you start graduating up, um, if there's something that's specific to the patient that they're a little worried about, they might, talk through it with you, or scrub in. But aside from that, if you like, if it's something you've been doing and you feel confident, they're available, if you have a question or if you need help. But one of the things that our attendings do that I think is helpful, is, if you're worried about something and you're asking questions or asking for help, and they asking questions, assess the situation and assess that like it's safe and they just need to walk you through it. They might stand there and let you struggle for a second, like mentally to be like, hey, like what are your options for what you're gonna do next, or like, nope, you can push through this part, like that's okay. And I feel like that's helpful to like have that feeling with support and somebody who can fix it, um, while you're doing that, than rather when you're out in practice. Yeah, but I think similarly for DR call, we also take independent call. It's only one resident. We do it a week at a time, for nights, and then weekdays and evening swing shifts. We start a little bit later in our 2 year. We start like September, with independent call, but there's a lot of buddy call for evenings and weekend days where you're sitting with a senior resident as an R1, and pretending that you don't have anyone to read out with, and then they are going through your studies, and going reading them out with you if you have questions, and preliminating them out. So it helps you kind of get a grasp of the types of studies that come in after hours.
Awesome. You were briefly talking about call. Can you talk about what call looks like at your program? And then also, what does a post-call day look like? And then how many days in a month you're usually on call?
So like I said, for DR call, we do a few weeks out of the year, maybe like 4 to 6 of nights, and then a smattering, a couple weekend days per month. And then a couple times a year, we'll do the evening swing shift. For IR call, it ends up being a little less than 1 week out of the month. We take home call. So that means that we're not in house. They'll be paging us or calling us at home, and we just have remote access to try and talk about what's going on with the patient, look things up. We take that a week at a time. So that starts at 6 a.m. on Friday, ends on 6 a.m. at 6 a.m. the following Friday. So when you're doing that, you're typically with one attending for the weekend and then a new one each day throughout the week. Um, and Yep, so just anything that's coming in as a consult goes through you. So, during the day, you and the call attending work together to work up inpatient cases that are coming through. You also get to be in, like, they all kind of go to the same room unless they need to be decanted for whatever reason. And like those are your cases, you own them. So even if you're, an R2 taking call for the second time ever, like you get to do those fun big cases that you're less experienced with. The attending just scrubs in, and you're assisting them. Yeah, so that's kind of how it works. And then your post call day, if you did get called in overnight, then you come in year round, and they do their best to get you out of there as soon as possible, usually like by noon. So, if you had really bad sleep that night before, but if you didn't get called in, then you just are rotating in your next room the subsequent day.
Yeah, in the interest of time, I'll try to keep it brief. We have a similar setup, similar amount of call. One thing I'll point out is that at our program, on the surgery side, the DR side, and the IR side, all three, we have a night float system. And I think it sounded like you guys have that as well, Marie Louise, right? You guys have just like
For
somebody on
DR.
nights for DR?
Yeah, not for IR.
Okay. Oh, okay. Okay.
Yeah, we
So
just
we,
take home call, and if they call us at 3 in the morning, we go in.
oh, I see. Okay. So we have night float throughout all parts of the journey. and different programs do it differently. What's nice about Night Float is that, for 2 weeks or for a month or whatever, you just have like a consistent sleep schedule. It might be a flip sleep schedule where you're working during the night and sleeping during the day. But the more Night Float that exists, then the less call you have, like one off, like a random day where you have to like come in the middle of the night. So it's nice, especially if you're at a big program. There's a lot of people who can kind of rotate on night float, and overall, it just means less disruption to your circadian rhythm in your life. So that's just one thing to consider.
Awesome. We have several questions in the chat, but I know there's another question from the audience. Shane, if you want to unmute yourself.
Hey guys, thank you both for being here tonight and speaking to us. So Subhash, I know you mentioned doing a CA, which I'm assuming was with the vascular surgery department at Rush. What would be your advice for someone who's debating between vascular surgery and VIR?
Oh man. Yeah, I mean, I was asking myself similar question. And also I was like, oh, should I do cardiology or like how do I make this decision? So, if you're debating those two fields, I'm going to assume that you're interested in arterial work, specifically PAD, and also probably some venous work. And obviously, all three of those fields do that, right? IR, cards, vascular. You should do vascular surgery if you like open surgery. If you don't like open surgery, then I'd say definitely don't go into vascular. There are some vascular surgeons who do predominantly endo work, but you don't want to go through all that training just to like lose those skills. Um, I ended up doing like even knowing I was super interested in PAD, I ended up going IR obviously or VIR. And when deciding on that, my thought process was, okay, I want to be able to offer endo interventions for PAD and venous, but I also like the huge variety of things that we do. EMBOs are cool, like UFEs, PAEs, GAEs. Not only are they interesting, fun procedures to do, they can be very quick. They can also be a great business model. You can do these procedures in any kind of setting, inpatient, outpatient, OBL. So you just become super versatile if you're an IR that can do these things. Now, the caveat is if you're an IR doing these procedures, then you need to make sure that you figure out what your goals are early on. And if you do want to offer something kind of unique like PAD, you got to train at a program that does PAD. Conversely, if you're, let's say it's not PAD, but you want to offer prostate embos, you got to make sure you go to a program that does that. So just try to like look into your crystal ball, figure out what you're interested in, what you can make a job out of, what you want to make a job out of, and then make sure you tailor your path to kind of fit that if you're able to.
Do you
Well
have
said.
anything to add, Marie Louise?
No,
No.
I saw my first amputation was like not vascular. So I was more between cards and IR because I was interested in the intravascular. And similarly, I there were other procedures that I liked more that IR does. So
Yeah, for me it was the 10-hour aorto bifem bypass and retracting with my hunched over.
yeah.
My spine didn't like me the next day.
I'm gonna start getting to questions
Thank
in
you
the
both.
chat. You talked about the OBL side of things briefly, Subash, with EMBOs. There's a question that asks, I know you guys are still residents, but do you guys plan to go more academic side or the OBL side? What does attending life look like?
I'm leaning a little bit more towards academics right now. I think given the current market with radiology, there are a lot of like jobs that they're wanting people to read more diagnostic or like do portions of jobs in some private practice spheres. Obviously, in like the OBL, I think you're not necessarily doing that, but I like having different levels of trainees all working together. I think having people you're teaching keeps you on your toes. And I think in IR, you definitely need to stay on your toes in terms of, keeping up with the new research and that kind of thing.
This is a great topic, and like there's so much to exploring like the IR job market and how things look differently, whether you're an academic, private, OBL, and like this definitely deserves its own lecture. I can't really dive into all the things that I want to say in a time efficient way, but I just want to like give you a couple of broad like concepts or pearls. So it's really important to understand in your guys' stage of training that you're probably attracted to IR because of all the super cool, cutting edge, complex procedures that you've seen either on the internet or maybe you've seen them in person. And you're like, wow, this is so futuristic. This is so interesting. I want to have this job. Now, in order to do those types of procedures, you, in a big picture sense, the two types of jobs where you can do that are academic or OBL. Now, I mean, there's some exceptions, but predominantly, those are the two job setups where you're going to be doing a lot of those procedures. Just like Marie Louise said, if you're working in the private world, um, about two-thirds of the private world jobs are owned by diagnostic radiologists, and they want you to read about 50-50 IR/DR. And that distribution can change, a little bit more in the IR favor, more in the DR favor, but imagine yourself doing a 50-50 job switching back and forth. I'm not saying that reading some DR is a bad thing, but I am saying that if you're in that type of job setup, they may not like that you're taking time away from reading DR to go build your practice or to go see patients in clinic. And then there's competing interests, right? When your boss is a DR and doesn't understand that you need to like that you may need to spend a couple hours on this challenging IR case, even though it might make more RVUs to be reading 10 CTs or whatever. It gets really into the weeds with the politics of it, but just know in a big picture sense, some jobs let you do the big cases and some jobs don't.
Thank you for both of your explanations. Um, there's a few questions that are asking about both of your intern years. So if both of you can explain whether you did IM or Gen Surge, and then if you can also touch on the pros and cons of each.
Sure, sure. So I didn't have much of a choice. I'm actually at a categorical program, so they force you into the surgery year. And so I'll just be transparent. I didn't apply to any surgery prelim years. I only applied to TYs and medicine because I don't know, like if given the choice, a lot of people will go for the more lifestyle conducive option, right? But having said that, I was really hoping I would end up where I did, and I thought, okay, there's a pretty strong chance I'll end up in surgery whether I want to or not. Um, so when I was a med student, like surgery was just awful vibes at my program. The rotations weren't fun. Everybody was bossing me around and kind of mean. But as a resident, it was a lot of fun. I was working long hours, but I thought the major pro was everybody else was busy operating most of the time, and I was left alone or I was left with other interns to just figure it out. And you become really autonomous. Autonomy is key on the clinical side, and whenever you're autonomous and put in like very high volume situations, you just get really, like really damn good at being efficient. And I think all those skills come back down the road whenever you're doing IR because you're managing patients clinically in the same exact way. So my big takeaway from surgery was I felt like clinically it was an awesome experience.
I mostly applied to medicine years, and that's what I ended up doing up at medical college. I enjoyed the year. My rationale was that an intern spends a lot of time on the floor, whether they're medicine or surgery. I do think that there is a benefit, like for my colleagues who did do surgery years, going into radiology and IR, having done a surgery year, because you spend more time, thinking about pre and post-op problems and like the pathologies that come and those complications, and that's a lot of what you see. And that's what a lot of the problem solving you end up doing as an IR. I think that I still was able to see, a lot of those complex patients. I, had analogous experiences like on cardiology or like with liver patients. So I think that was still like a good experience. I just didn't want to have to wake up at 4 a.m. or 5 a.m. every day. So I was like, all right, if I'm gonna spend however many months working really hard on the floor, get a little bit of sleep. But
Yeah,
it was nice. I did want to go to like a larger academic institution so that I could see those, sick patients. And they do lungs, hearts, like all kinds of stuff up there. Sorry, go ahead.
yeah, it took a few years off my life. It gave me a few extra wrinkles. I'm sure you also got great clinical experience, but yeah,
Yeah,
both are great options. It's just, you know, it's kind of like how long do you want to be in the hospital, and there's a trade-off to either side, but
yeah.
you kind of get it all down eventually.
There's another question in the chat. I think this is more directed towards you, Subash. So as you transitioned from a procedure-heavy intern year to DR, how did you keep up with the clinical skills you learned in surgery?
Um, I think a lot of the clinical part just kind of, at least for me, it's just stuck like so deep in my brain. And even on diagnostic radiology, I feel like I still utilize a lot of the clinical part whenever I'm reading studies. So every time I get like a CT or whatever, I spend a few seconds looking at the chart, being like, okay, what the heck did they have done? What's their history? What surgeries did they have? And knowing that really informs the way that I read the study. Like it totally changes the way I read it because I'm like, okay, this is what we already know happened, and here's their question, here's what they want to know. But aside from just like reading images, at my program, we still do a lot of clinical rotations even during the diagnostic years. So we do 2 months of IR a year, and we also do 1 month of ICU a year. And during these times where it's you need to be extremely comfortable with clinical work, especially ICU. So that's 3 months out of the year where you're treating hardcore, clinically complex patients. And even if you didn't want to, that kind of forces it to all stay fresh.
Thank you for that, Subash. I don't know if you want to add a little bit to that, Marie Louise. Maybe if there's any skills from your medicine year, how did you like keep those intact during your DR years?
Honestly, what Sebastian said, the most important part is the clinical thinking. I think that one can slip into just looking at the image in front of them, and I think that you're doing the patient a disservice every time if you're not, checking the chart and thinking about the whole picture when you're looking at their imaging. And
Yeah, it's crazy. I think a lot of people don't. I feel like
I
I know other
yeah
residents, they don't really look at the chart. Attendings probably
yeah
don't either. And it's like, how do you even read this thing?
yeah. No, I had a spine this afternoon and a patient with achondroplasia, and like yeah, my attending looked at it right as I was opening it. She was like, "There's something going. What is this?" And I looked in the chart and it was like, "Oh, that's why."
Yeah, definitely.
Awesome. I want to take you guys back a little bit, and there's another question in the chat. I want you guys to reflect on what first got you interested in IR. What was your aha moment when you realized that it was the right fit for you?
I go first. I actually was in high school. We had a local hospital that would do summer program for people interested in healthcare. It was like 2 weeks. You spend it in a hospital basement. You get to do some like pig organ or cow organ dissections. It was deeply nerdy, but you got to shadow in the morning. And I got to shadow it was a community hospital in IR, but they were doing, all the procedures. And so I saw a couple things, but among them, I got to see a Y90 for the first time, and I'd just taken physics. And so like I knew my different kinds of radioactive decay. And I thought that the way that they were approaching like that patient specific issue, and like I know that's a common case, but was so elegant and thoughtful. And I loved that there was something that someone could do in the space between where like surgery is not a great option, chemo is really not a great option, being able to tip somebody in the right direction, either like bridge to transplant or give them like really great like palliation experience. And I remember like walking out of there too. I'm a very hands-on person, just being like, yeah, man, like if I could do this every day, I think that would be really great. And like honestly, throughout all my training, throughout college, like everything that I considered outside of that, I was continuing to compare to IR. And so I stuck with it and I'm happy about it.
It's so crazy. I think like so much of the journey is just serendipity. And I'm a big overthinker, and like when I was a med student, I just really wish I had a crystal ball and I could see what my life looked like in 10, 15 years, and I could compare it to all the other alternate universes where I did something different. But that doesn't exist, and you guys have very limited info at this point in the journey. And even with that limited info, you're gonna have to make enormous life decisions. What specialty do I pick? What program do I go to? What city do I live in? It's so scary. But like for me, it was just a lot of serendipity. And a big part of my journey was being just like you, Nick, and all you guys who are tuned into this Zoom call today. For me, it was just having the mentorship and the community and the support of people like Dr. V and his friends and other passionate attendings kind of around the country who get involved in this kind of stuff like WCVIS. Um, as a med student, I got, I don't know, like you just go on these rotations, you get bossed around. Half the time you're a fly on the wall, like nobody cares about you. Like they're just like, okay, present the case. Oh, why, why didn't you have a pen ready? And it just doesn't, they're not, they're not really mentoring you or uplifting you all that much a lot of times. You meet people in this field and they all care about you. Like they want you to feel what they felt when they first discovered this. They want you to feel that mentorship, and we're all just kind of passing on those good vibes to the next generation. And like one day you guys are going to do that. But really, it was the community. It was having people who consistently checked in on me and kept being like, "Oh, did you hear about this thing?" Or "Oh, like I did this cool case." And so that was like the vibes part, like the social part. And then so I already had like a good attitude about it, like going into it, just because people were nice. And then it made it way more fun to learn about what we were actually doing. And every step I'd learn, oh, like here's how you do this cool procedure, or oh wow, like this procedure allowed this patient to avoid a massive surgery that maybe they wouldn't have even survived. Like we could do all the same benefit to the patient with a hole this big. So I realized like, okay, the vibes are good, the procedures are cool, they're relatively quick and easy, people are happy. All the IRs that I've met, they're always like the coolest people in the hospital and they're happy. So I don't know, like what's not to like? It's just a recipe for like a fulfilling career. There's a guy named Dr. John Lippman. He's the director of the Fibroid Center in Atlanta. He's a big OBL guy. He's done more fibroids than anybody in history, right? And he has a talk like on Backtable, and he goes on all these radio shows and podcasts and stuff. He talks about this concept called ikigai. Has anybody in the audience heard about that? Nobody? It's a Japanese word, and I mean, maybe I'm butchering it, but it just means that your purpose in life is where it's not just defined by one attribute. It's where all these different attributes intersect. Your purpose in life is where you're doing a service to the world, you're having fun, you're you're compensated and you can live well, you're learning things, you're teaching things, all these different things. Because like I said, we're putting so much of our lives into it, so much time during the day. So make sure it's like actually fulfilling you.
Awesome. Thank you very, very much for both of your pearls. It's 7 p.m. and I don't want to take up any more of your time because you guys are so busy. I want to thank everyone who came to our meeting today. We have a lot of events coming up in 2026. We have a very packed schedule. Yeah, any final words from our residents?
I think y'all are doing something really great, exploring this field. And I know a lot of you are earlier in med school, and I think so many people don't find IR or don't get to like experience it until so late in their training. So it's really nice that there are organizations like this that I think I did a similar symposium. It might have been this one when I was in med school, and it was just so nice to get to like immerse myself in it. And so, I think you guys are doing great. I'm gonna throw my email in the chat if anybody has additional questions, or wants to connect.
Yeah, I have full faith that everybody in this chat is going to get exactly where they want to be and where they should be. I know a lot of you guys are so stressed out at different parts in the journey, but it all works out. And if I can give you one piece of advice that you take with you, it's just to stay involved in this organization, stay around the field, and just being motivated it takes you very, very far. So hope to see you around at the next one.
Awesome. Thank you very much. I wish everyone a happy holiday season, and I'll see everyone in 2026.